Hi, everyone. We are so grateful you are here with us today. We would like to go ahead and start the webinar. Thank you for joining on time. Great to see each and every one of you. Today, we are hosting an open webinar on behalf of Palliative, ICPCN, and Two Worlds Cancer, along with the local partner in Bangladesh, Dr. Farzana Khan's organization. So we are so grateful that you are here. My name is Erin Das. I'm a palliative care nurse supporting the work that's happening in Bangladesh and globally with Palliative. We have a great lineup today, so we will start right away. We will be recording the session, so if you need to leave or if you miss out on some, we will be sending around the recorded link. So the ECHO series on palliative care provision in humanitarian settings is proud to showcase the topic for today, which is providing palliative care for neonatals in humanitarian crises. We have three speakers here with us. The first will be Rachel, and Rachel is a pediatric ICU nurse from Canada who spent many months in Bangladesh supporting a hospital there for pediatrics in palliative care. After the case presentation, we will move on to a didactic lecture focusing on the topic of providing care for neonatals in these situations. And that will be supported by Dr. Megan Doherty. As many of you know, she's spent many years supporting the efforts and had the chance to live in Bangladesh as well, and is our mentor in general for many on this call. And then we will move on to Dr. Julia Downing, Professor Julia Downing, who is the Chief Executive of ICPCN, which is the International Children's Palliative Care Network. And we are very grateful that they are partnering with us on this call today. So we know that some of you are from Bangladesh, as this is the cohort we've been supporting, but we know many of you are not. We would love to learn more about you. So if you can take the chance to write who you are and where you're from in the chat. We have several other faculty members that are monitoring the chat. And if you have questions during the program today, please do either raise your hand or put your question in the chat. We will be trying to leave a lot of time at the end of the session for questions and answers. So those of us who are faculty members will be monitoring, and if we don't get to it during the session, then we'll follow up at the end. So again, thank you so much for attending the program today, and a very warm welcome to each of our participants. I'll pass it over to Rachel, and we can begin with the program.
Okay, thank you for that, Erin. I'm just going to share my screen. Let's see. See if I can do this. Sorry for the wait. All right, I think it's working on it. All right, can you see my slides or my notes right now? Good, okay, perfect. Awesome. All right, so thank you for the introduction, Erin. As I said, I'm a pediatric ICU nurse, and I worked for the past, I got back at the end of August working at an MSF, or Doctors Without Borders hospital in Bangladesh. So I'm going to be sharing a case today that we have a small child that we took care of back in the summer, last summer. And there's a few questions I want to propose for discussion, and we'll sort of explore these throughout the case, and then I'll welcome your input at the end as well. So the key questions I wanted to explore with this were, how could we better adapt the guidelines that our organization had put forward around caring for neonates who needed palliative care? How could we better adapt them to the context? How could we have better supported collaborative decision-making within the healthcare team among all the different disciplines involved? How could we have better involved the family in developing a plan of care for this child? And how could we have supported members of the team who had different opinions about how the care should have been managed? So our child that we were taking care of was a brand new 1-day-old neonate, a little baby boy. He was born extremely low birth weight and premature. He was born at 790 grams. And the estimated gestational age was a bit debated. We're not entirely sure how many weeks, but some were saying 28, but we think he was actually quite a bit earlier than that. He otherwise was healthy. So he was referred, and he was from the Rohingya refugee community. He was referred to our hospital from another facility because we had a higher level NICU at our hospital. And when he came to us, he had an IV cannula already in place and was receiving IV fluids. His vital signs were normal. His oxygen saturation was more than 90% on room air with no oxygen. And he was having very minimal respiratory distress. But otherwise, considering his size and gestational age, he was pink, active, had good tone for his gestational age, and was quite vigorous. Excuse me, move to the next slide. So in terms of our treatment and investigations, the organization I was working with had a guideline for sort of management of neonates, and the policy was that it's recommended to avoid measures that may extend the dying phase and prolong suffering, such as IV fluids and oxygen for any neonates that were born at less than 1,000 grams. This was based on data showing that the outcomes for these babies were not good. And so that was sort of the policy that we were working within. But we decided as a team, because the child came with IV fluids already infusing, and there was a lot of strong opinions within the team that we should continue those. And so we left the IV cannula in place and made the decision that we wouldn't reinsert a new IV cannula, but we wouldn't remove the one that was currently working. We decided to continue with continuous pulse oximetry. We did not give any antibiotics, oxygen, or caffeine, which would have been our normal plan of care for a slightly larger baby, because we didn't want to extend his suffering. And we made a decision that we wouldn't resuscitate or give CPR if his heart were to stop beating. On about day 3 of life, the child was still alive, and we were starting to feel uncomfortable with the fact that he hadn't been being fed. And so we made a decision to start, we call trophic feeds, like a very small amount of express breast milk, about 1 or 2 milliliters every 2 hours by nasogastric tube, because he didn't have an adequate suck. Around that day, the IV cannula stopped working, and so we removed it and didn't place a new one. The child lived for about 10 days and then died at that point in our hospital. In terms of pain and symptoms, based on the scoring system we use is the neonatal facial coding score. And according to this, he didn't appear to be in pain, so we gave him a score of 0. He showed very minimal signs of respiratory distress, but seemed quite comfortable. He wasn't showing signs of interest in feeding or hunger, but we were sometimes giving just drops of breast milk in his mouth, just to kind of, because it can be a pain reliever for neonates, and then this small amount of nasogastric feeding, mostly for comfort and for also because the team and the family felt strongly that this should be done. In terms of nursing issues, so obviously the nursing team was very involved in the care of this child. One major concern for this baby was temperature regulation. So in our hospital, we don't have incubators or isolates, and we do have radiant warmers, but they're not ideal for sort of long-term warming. So this baby did have issues with maintaining his temperature. We tried to encourage the mother and the family to do kangaroo mother care or skin to skin with this baby. And the point I mentioned about the confusion was the mother was very dedicated to doing skin to skin with this baby, but the nurses expressed some concern to me that kangaroo mother care had been framed to her as a way of extending the baby's life, that the mother was told, this can help keep the baby's temperature good and keep the heart rate normal and can help your baby survive, while we were at the same time sharing the really difficult prognosis for the baby. So they were concerned that there was maybe conflicting messages because of that. The other issue was that the baby lost a significant amount of weight, and so because he wasn't being fed and couldn't for a number of reasons. And so he began to look quite emaciated and thin. And initially the nurses were continuing to do daily weights on him, which was our normal policy in NICU, but we had a discussion after a couple of days that this wasn't needed for him. But so that confusion, as well as just visually the weight loss, was upsetting to some of the staff. In terms of psychosocial and family concerns, so the family, both the mother, father, and also a sibling were a 2-year-old sister, were quite involved in the care of this baby. The mother stayed at the hospital all the time, and the father came quite frequently. They were all very affectionate with the baby and actually gave the baby a name, which was slightly unusual in our context this early. And the 2-year-old sister came to spend some time with her little brother, which was really special. The family did express some concern that the baby wasn't feeding and wasn't urinating at one point. And so I think there was a bit of a gap in terms of understanding what was happening. In terms of spiritual concerns, so this was a Muslim family, and so a local imam came and did the azan, so a prayer for the child, and they actually gave, the father chose to give the baby a name quite early, and they seemed quite aware of what was happening, but I think the amount of spiritual support for the family was appreciated by everyone. Then in terms of communication, so the team, so I was unable to hear directly from the family because of language barriers, sort of their understanding of the prognosis, but the team that I talked to believed that the parents really understood well the child's prognosis. But there was, I think, a bit of lack of clarity about what the family wanted. So I was very aware of the team's beliefs and concerns, but I think there was a bit of a lack of understanding of what the family wanted for this baby. And then the issue of the kangaroo mother care confusion. One of the main things I just wanted to talk about in this case was, so between different members of the team, there was a lot of differences of opinion about what should be done. This was one of the first neonates that we sort of decided to really focus on palliative care from the beginning and not sort of attempt more aggressive treatment. And so I'm just at the same time I was doing a research study, and so I actually did interviews with different staff members about this case. And so I'm going to share just some comments from 2 different doctors. This doctor mentions that with premature babies, they felt that our protocol, because it was very clear about the 1 kilo sort of cutoff, I guess you could call it, that was very reassuring. So having that information, that they knew that there was evidence that went behind this decision, and so that felt reassuring to them. They also talk about, in our context, we don't have a proper ICU, we don't have surfactant for the lungs, we can't intubate. And so the awareness of the inability to do these more extensive treatments made them comfortable with this plan. The other thing they talk about that I think is important is, they said, sometimes doing more is doing worse. We need to accept that as healthcare providers, the first thing we always need to remember is to not harm, to do no harm. And by giving treatments, many times we are harming. So their overall perception was that the 4 of them, the parents, the sibling, and the little baby, stayed together until the time that the baby passed, and it was very peaceful. So their sort of overall perception of this case was very positive. It's a sad situation, but they felt that it was managed quite well. Another doctor, this is a local physician, expressed quite a bit of concern about this case, and and said that he was speaking sort of on behalf of some of the other staff that had mentioned these concerns. And he spoke about how they or the family can complain that we are not giving any feeding to the baby. How will the baby survive without feeding? So what is the treatment? And so there was this sense that feeding is so central and important. And so by not feeding the baby, that this felt very distressing to them. He also felt that by making the decision on the first day about the plan, rather than sort of seeing how things go over time, that didn't feel okay. He felt more comfortable with sort of attempting things and then stopping them as they were shown to be ineffective. He was more comfortable with that approach. The other thing he mentions is that even I saw 600 or 700 gram babies survive in another hospital. So this encouraged him, or this made him think that it was appropriate to refer. So, you know, if I can treat a baby and I see the baby is dying and we are not doing anything, that gives me some bad feelings. So this feeling of not intervening made him uncomfortable. And he also, I think, felt that we weren't adequately considering the opinion of the family. So he talked about being aware about all the research that goes into the protocol, but if the family wants us to feed or to do other things, that we should consider that. So those are some of the sort of differences of opinion. So some of the key areas of learning for us as a team in this case were, first of all, that after this case, we really made an effort to try to debrief, especially some of the cases where we had neonates that were born like just a little bit over 1 kilo, 1 to 1.25 kilos, who really had very poor outcomes. Just to try to talk to the team about, even though we did everything for these babies and we intervened, they still had a very, very low chance of survival. And I think observing that and talking about that as a team helped them to feel more comfortable with our plan for these very, very small babies. The other thing is just generally this helped to increase the acceptance. We also talked about the importance of not starting some of these treatments from the beginning, because sometimes it's harder to take away things than it is to not begin them from in the first place. But I think the most important thing was, with our nurses in particular, they're sort of at the bedside and they are doing a lot of this care, and they don't always feel as comfortable speaking up when they were concerned directly to the doctors. And so what we did was a lot of just trying to encourage people to express what their concern was. And, there was a balance between saying, no, this is not an appropriate treatment to give, and potentially being flexible with if everyone really felt strongly that we should continue a certain treatment and it was not likely to be too much of a burden on the baby, sometimes we would continue. Yeah. So I think some of the ongoing challenge that the team, I think, is still facing there is involving families in decision-making when life-prolonging care is not recommended. So when we really feel like medically it's not the best approach, but when the family feels strongly that we should continue, and including families in those decisions when there's a really a limited sort of understanding of medical care and how it works in this setting. So just a bit of a summary, we have this little 790 gram premature baby, focusing on comfort and minimal intensive supports. Baby died at day 10 of life, and just that there was a kind of a diversity of opinions about the case. So then, yeah, I just have these questions that we can consider, but I think Megan will share a little bit first, and we can come back to these discussion questions after. Thank you so much.
Thank you, Rachel. That was a really insightful case, and I hope many of you who are listening in are thinking also of situations that you find yourself in. I think that's one of the unique parts of this program. As we all gather together, we can think and reflect back on other cases we've also been through, and we hope it will be an opportunity also for you to debrief if you haven't had a chance to debrief with your colleagues. So we'll move on to the lecture. I think one of us could even put, Rachel, those comments in the questions in the chat, just for those of us that it's easier to read it. But we'll now go on to Dr. Megan Doherty in terms of the didactic lecture for today. So you're welcome.
Thank you very much, Erin. Can someone just give me a thumbs up that everything's slides are showing and stuff? Perfect.
Yeah, oh, fine.
Great. So I want to just talk about two key points, and it really complements exactly what Rachel's saying. We wanted to show Rachel's case because it really illustrates the ideas, and it's like shows you the real situation, how we manage these little babies in these situations. So I'll just describe a little more in detail the types of babies that we might encounter. Rachel's mentioned about, you know, in their hospital, it was babies under 1 kilo, but we'll tell you about some other types of babies where this might be an appropriate type of care. And then I'll talk a little bit about some of the comfort focus measures we can give these babies. And just as a reminder, so that we know what we're talking about, we can define neonatal palliative care very similarly to how we define palliative care for children. So this is very much the same definition as for other children. It's that active and total approach to care from the point of diagnosis or recognition. So I use the word recognition because I think many times when we're in a humanitarian setting, we don't always make a diagnosis, right? We just recognize clinically what's happening to the patient. So I want to empower you. If you don't have to have the diagnosis, you just have to recognize what's happening. And it continues throughout the child's life. That we focus on physical, emotional, social, and spiritual elements of care. And Rachel's case illustrated how we focus on all those things for that baby and their family. It focuses on improving quality of life for the neonatal infant and supporting the family, managing distressing symptoms, and care through death and bereavement. And if we think about neonatal palliative care, this is one way that some people tell us we can think about it in terms of, it kind of has 4 big components. This is from some authors that you can see at the bottom who created a neonatal end-of-life palliative care protocol. It's not the only way to think about it, but I find it helpful sometimes to think about different aspects of how we're going to care for the babies and their families. So in blue on the left here, we have communication, goals of care, decision-making, because that takes up a lot of our time with these babies. Then there's the idea below that in orange of making sure we optimize their quality of life and manage their pain and symptoms. And we'll talk about some ways we do that. In green, we have just thinking about grief and bereavement and sort of the challenges for the family themselves, but also I put the staff here too, and Rachel really illustrated that for us. And then I've included the 4th area would be just looking at the family's support emotionally, culturally, and psychosocially. And if we look at around the whole world, we see that there are a lot of babies who might need neonatal palliative care. Remember that newborn deaths account for 43% of all deaths in children under the age of 5. So there's a lot of patients that might be in this category. There's 3 million babies that pass away every year. Now, a lot of these are things that sometimes are preventable, or in some situations they're treatable, right? But in a humanitarian setting, that's not always the case. And if we look around the whole world and we look at the reasons why children need palliative care at the end of their life, there are many, many different conditions they might have, but the biggest 2 is the congenital anomalies, which is 25%. So we're going to see a lot of this in very small babies, and also the neonates. So this is just showing you for all the children who need end-of-life palliative care globally in a year, what is the underlying reason? And those are the biggest 2 reasons. And I've given you another list showing a bunch of different conditions that neonates might need palliative care for. So extreme prematurity or extremely low birth weight, genetic conditions. Again, you might not make the diagnosis, but you might suspect that the baby has trisomy 13 or 18, because you would make this based on the clinical features you see in the baby when they're born, their appearance, and the things you find. Major central nervous system anomalies like anencephaly, or if you're aware and the baby has like other major brain malformations. severe congenital heart disease or other severe congenital anomalies like abdominal wall defects like gastroschisis, renal agenesis, and then overwhelming or irreversible illness where the burdens of continuing the treatment exceed the benefits, like babies who have severe necrotizing enterocolitis, sepsis, intraventricular hemorrhage, or they're not responding to treatment. And I highlight this because in settings where you have a lot of resources, this bottom one is not very many babies, right? Most of the time you can combat very severe illness. But in our settings in humanitarian where you have to make decisions much more quickly, you don't have all the same resources, then this can actually become a very large proportion of the neonates that need palliative care. And our experience in our neonatal palliative care program in Hyderabad, India, which is not in a humanitarian setting, but just in a large pediatric hospital, is that in that setting, that's more than 50% of the babies is in this last category. And also we know that we can provide palliative care in an NICU setting, and we can apply these palliative care principles to babies, regardless of whether the treatment goal is obtaining cure, prolonging life, or exclusively palliation and comfort. So there is recommendations that we also can incorporate these principles of palliative care into the care for a lot of the babies because they're very critically ill.
Megan, just to interrupt you, if you want to make me host, I can also monitor the muting.
Thank you. Good
Yeah.
suggestion. So I think there's a couple people who keep unmuting and then it's distracting me a bit. I apologize. Okay, so there's sort of two times when we can do, sorry, go back here. So there's two times when we can think about needing to start neonatal palliative care. So sometimes you might be able to do it early, meaning somehow the patient is known to be pregnant with a baby who's very ill and the baby might not survive, having had some problems in utero or being diagnosed with something very serious. This is not the majority of cases in humanitarian settings because you usually don't know about what the baby is like until they're born. But if you have a mother who's in labor and the baby's very premature, you know that she's not very far along in the pregnancy, then maybe you can do the early neonatal palliative care. The more common situation is slightly later, and you can integrate the palliative care into the neonatal care or the NICU care. And I'm going to illustrate that in later slides, so I'm not going to go through all these points. So let's look at really how we could give the palliative care for neonates in the humanitarian settings. Practically speaking, this kind of gives us a flow or an idea, and we have this on a one-page handout of what babies to think about and then what to do. Okay, so here's your three main categories you're going to have. Preterm babies at the limits of the viability. So this is typically, it depends on your setting, depends on your resources, but majority of newborns less than 1 kilo in humanitarian settings, it's not possible to support them to survive. So that's why Rachel was saying those ones we would really recommend you go for palliative care. But again, you can review data from your own hospital if possible, or sometimes you just have to make decisions based on how viable and how vigorous babies look or how they're responding to some treatment. The second group is if they have severe congenital anomalies, like I listed some of the common ones. And again, that depends on what you can access. For example, in Bangladesh, a baby with gastroschisis in the Rohingya camps cannot access surgery or is too unwell to access surgery. So they would be a baby that might fit into that category. And then I mentioned before that third category, life-limiting disease, unresponsive to available medical care. So for all of these, you work with your clinical team, just like Rachel described, and you identify this is a child who has a very low chance of survival given the health resources that we have. And then we need to communicate that with the family and the mother, just like Rachel described. There was a lot of communication that has to happen. And we don't have time to go over all that today, but the same spikes model that we've been mentioning in our courses and many of you are familiar with for breaking the bad news, telling the family, that can be used. And then we can really give comfort-focused care, which is exactly what Rachel described for the baby. Keeping the baby with the mother or the caregivers, based on the wishes of the family, of course, doing kangaroo mother care or skin to skin care continuously if possible, but as much as the mother feels comfortable to do, providing breast milk or feeding for comfort. So sometimes the nurses think, well, this baby's going to die, so what's the point in feeding them? But we should feed babies if they look like they want to be fed. If they're showing signs of hunger, we should offer them a little bit of milk so that they are comfortable. And that won't necessarily be enough to sustain them to grow or, gain weight, but that's comforting for them. If they can take it and they want to, we gently provide it via syringe or via breastfeeding. We can give sucrose because this is pain relieving for babies. So if the baby appears to have pain, in Rachel's case, the baby didn't have pain, but if the baby did appear to have pain, we might give that. And we're not going to have time to go over how we manage all the other symptoms a baby might have, but we should ensure the symptoms are managed. And then, like Rachel mentioned, we can consider stopping or avoiding starting interventions that cause discomfort, like vital sign measurement, blood tests and monitoring, IV fluids, IV medications, oxygen, nasogastric feeding, and sometimes phototherapy has been initiated, and we wouldn't continue that. But again, I think one thing Rachel really mentioned and highlighted was it's a process of discussion and negotiation and coming to a place where you find an appropriate path for that patient. And here's the things you should consider, but it's a bit different for every patient. Depends on what things have already been started, and can you remove them or do you have to continue them? And I agree with Rachel's point. It's harder to stop things after they've been started. Sometimes the idea is avoid trying to start things that might be difficult to stop later, and we're not going to help the patient. And lastly, the third component of the care is the care planning. So where should the patient be cared for? Sometimes the family wants to take the baby home, and we can help them to do that. We try to give unrestricted visiting so family can visit, like the 2-year-old was visiting this patient. We can give counseling support through ongoing communication with the family, having the mental health team or a counselor, whatever's available, provide the family with support, and then debriefing and support for the healthcare team themselves. And again, for the very end of life period, asking permission to the family and then informing them about what to expect, incorporating uncertainty. So one thing that happens is that we think these babies will die very quickly because they're very, very small or very sick, and you can't imagine how the baby would live for more than a few hours. But it's unpredictable with these types of babies. So don't give a very firm answer like, oh, it's going to be 3 hours or less, because you don't know. And if you say something and then it's not accurate, then the family starts to mistrust you. We can use this I wish, I worry framework where we say, I wish things were different, but I worry that your baby looks like he is coming very close to the end of his life. It's a very gentle way to share with the family that you're worried that the baby is dying. That's what you see. We do not perform CPR for these babies, like Rachel mentioned, and then we think about the family's spiritual practices. I'm going to stop there just to allow Dr. Julia to give us some of her thoughts as well. But in summary, we talked about that we can provide palliative care for neonates with a wide variety of conditions, and particularly in humanitarian settings, it's babies with extremely low birth weight, under 1 kilo, severe congenital anomalies, and severe diseases that are not responding to the available treatments. And the palliative care really focuses on comfort with skin-to-skin care, sucrose, breastfeeding, and feeding for comfort. And we should discontinue or really avoid starting intensive care, things like what is listed here.
Thanks, Megan. It was really detailed, and I think gave people a lot of really practical tips to start implementing in their work if they are working with babies like this. We won't take too much time, but again, if you do have any questions about what's going on, there is a lot of possibly new information for you. So please don't hesitate to put your questions as they come up into the chat. We'll have people that are checking through on that. And now we'll welcome Julia Downing. Thanks so much, Julia.
Thank you, and it's good to see everybody today. And I'm going to follow on from both Rachel and Megan's presentations. Specifically, I'm going to be thinking about some of the psychosocial, some of the spiritual issues, some of the cultural issues, and also how, as health professionals, as a nurse, I'm a nurse, we can care for ourselves and support ourselves in these situations. So we've seen this from Megan already, and I'm going to just touch on a few of these wider issues. I also find this quite helpful, particularly within the context of humanitarian settings, that it's not just the medical and the physical, but obviously the psychosocial, but then attitudes and beliefs. And certainly within some of the humanitarian settings that I've been involved in, that has been really key in the care that we provide. And then information and communication preferences. We know that this is a traumatic experience for the families. We know that it might be planned that they were having an admission, that they knew that they had a baby that has a life-limiting condition, or this all might be happening very quickly in an emergency situation. We also know that often, particularly in crisis situations, both parents might not be present. The family might have been split up for various reasons. So there's not only the worry and the trauma as to what's happening with their baby, but also maybe their siblings. And what care is available? We've heard in the previous presentations about the different options and the lack of facilities in some place. Some places might be quite high tech, even though they're in humanitarian situations. Other settings will not be. So it is a challenging experience. And many of the parents will express their feelings of loss of control, of isolation, fear about what's going to happen to their baby, fear about the future, fear about, because of the situation that they're living in, even if their baby survives, how are they going to care for a sick baby? Whereas it should be a time of joy, of expectation, of family, celebration, of perhaps traditional and cultural practices. So within the humanitarian context, we have the ongoing psychological issues of that context itself, alongside all of these other added feelings. So we know that communication is vital, and we've heard through the case study and through Megan the importance of communication. But we also know that in many of the settings that we work in, there might be challenges with language. We might not be able to communicate well with the families. Family members may not be there, and maybe the decision makers and the key communicators within the family are not there for whatever reasons. So how do we work within that situation? And also this need to check understanding. We think we've communicated something, but what is the parent's understanding of what we've communicated? So trying to make sure that some of these issues around communication don't occur, because we're continually having good communication, checking understanding as appropriate. As I've said, information is key, but we can't always provide it. As Megan said, we don't know how long a child is going to survive. We might not know what the condition actually is of the child in terms of the underlying condition. We might not know what happens next. But if we can at least explain this, if the families, the parents can know who to talk to, and also how to discuss some of these things with other family members who aren't there. Maybe they're talking to their partner on the phone, or maybe they're having challenges in communicating with other family members. So trying to provide information, but being realistic and honest and open as to what information we can provide. Now, we know that there's varying situations, neonatal intensive care unit, and my picture here is clearly of a child in a well-developed neonatal intensive care unit, and many of the settings where we work don't have that. I've worked in hospitals and health centres where we've had one oxygen that we're sharing around all of the babies. In some where we haven't had oxygen. You know, the resources are varied. So we need to try and provide some reassurance. Parents will feel overwhelmed and frightened. They might not feel safe depending on the context that they're in at the moment. I mean, we've seen pictures and heard stories from our colleagues in Ukraine of hospitals being bombarded and trying to continue to provide care in that situation. They might not understand, the families might not understand what is happening. They might find it really difficult because they can't undertake their traditional parenting roles. We've heard about the encouraging the skin-to-skin care, but we've also heard about the challenges of not feeding and feeding and what that means for an individual culture and to individual family members. And just trying to explain and provide information as to what they can expect. Another key thing that came through that case study was that of decision making. And there are critical decisions that need to be made. And we heard from Rachel some of the comments from some of the health professionals involved in that case. We also heard from Megan about the importance of trying to build trust and what is in the best interest of the baby, the concept of doing no harm, what is in the best interest of that little child. And this is challenging. We talk in neonatal palliative care about parallel planning, so planning for what we'll do if the child survives and planning for what we'll do if the child dies. So that parallel planning, but that can be confusing then for the family and for the parents. So how do we manage that? Including families where possible in the decision making. Now there was very clear rationale as to why the child in the case study shouldn't be resuscitated, but that could be a tension. When do we resuscitate and when don't we resuscitate? Certainly a tension for us as health professionals working in this field. And we may not all agree. We might have different views as to the way forward, and I think it's important to encourage that expression of concern, as we heard in the case study. We need to try and promote the well-being of the parents, and we've already seen that these parents are caring for a child in a humanitarian crisis and the implications of that. So how can we provide some support for the parents? How can we enable them to get support within the overall context in which they find themselves? This is hard enough for any parent with a child, with a baby needing palliative care, even more so within the context where many of us are working. What about the financial issues? Are there financial issues? Many of the parents that we care for in the humanitarian settings will be limited for their financial resources. They'll be limited to the wider family that they have with them. How are they going to care for their siblings? How are they going to manage the child in hospital? And it's all very well the immediate care, but what happens if this becomes a long-term issue? How are they going to provide for their child, for their baby and other siblings? So the financial issues, and then I've mentioned the whole issue around family and social support. We rely so much on our families, and you get into a context of war or refugees or the different humanitarian settings we find ourselves in, and many of our parents won't have that family support. They won't have the normal social support. If they're living in a refugee settlement, they might be unsure as to who their neighbours are. They might not feel secure or safe, and so trying to find ways that we can help and support the family is so key. And then the issue of discharge, if the child or the baby is going to survive, or moving on into that end of life care and supporting them through death. If the child is well enough to be discharged, where are they being discharged to? This is a picture of one of the refugee settlements in northern Uganda. What resources are there available? What is the future for this child? How are the families going to cope? If they need specific medical supplies, how are they going to get them? What about ongoing care if they're moving from one place to another? And are they able to take some medical records with them, so at least they can share with new healthcare professionals what has happened to their child to date? And then we've mentioned spiritual support and the whole existential issues within neonatal palliative care within the humanitarian context are so important. And we're working in environments where there's mixed, multicultural, multi-religious issues. There's traditions that they might not be able to follow. For example, if it's very important that your child is buried in the family plot, but if you are a refugee, you're not able to go back to the family plot. So what happens then? So lots of different things for us to try and think about and support the families. And throughout the whole process, there will be grief about what's happening to their baby, to their family, what has happened to the dreams that they had for their baby, what's going to happen for the ongoing care, the whole grief around the situation they find themselves in, and the grief over the loss of their baby when their baby dies. So we need to be thinking about bereavement care, and whilst grief is a normal process, we need to try and provide some support for the families, and how we do that will depend on the place of the child's death, of the baby's death, and whether if it's in a neonatal intensive care unit or a health centre linked to the refugee settlement or wherever they're living, they might be able to get support locally. But it's really important that we try and empower them and enable them to get some support. Ongoing complicated grief and bereavement can cause challenges, and we know that the parents we're working with are already living in challenging environments. And if we think about this, where I started a few minutes ago, the whole issue around attitudes and beliefs, and the whole importance of families needing to feel safe, and many of them will be living in situations where they don't feel safe, and then they have this additional issue around a baby that needs palliative care, a baby that is dying, and how do all those attitudes and beliefs impact on not only the care of their baby, but the care that the families need. And then as we think about this, I was highlighting as a nurse our support for nurses, but for all of us, I know that there's doctors on this call, there's counsellors, there's a range of professionals. We are working in challenging situations. Neonatal nurses, neonatal doctors, those of us working with these young babies, we face a significant risk when caring for babies at the end of life, and research has shown that there is a significant risk to the well-being of nurses and other professionals, and we need to try and find some way of managing that risk so that we don't burn out, and so that we are able to care for ourselves and to care for the babies and their families. And if we are stressed, if we are burnt out, that's going to impact the care that we give. But as health professionals, as individuals, we can develop our own resilience. We can develop our own resources to be able to work within this context. We know that within resilience, there's internal and external factors that are important. It's not just what's happening to us, but it's how we cope with that, how we manage that. And there's lots of work on resilience, and there's lots of theory behind it, but basically it's about us developing processes to enable us to cope. How do I, as Julia, look after myself as Julia to enable me to provide the care that I need to do this? And self-care and knowing ourselves is so important. And also knowing when we need a break. Often in high humanitarian crisis situations, workers come in for a few weeks and then they leave because they need that break. Now that isn't always possible, and that's not possible for many of us living and working in the settings where we do, but we know that we need to look after ourselves. So I guess key to all of this is looking after ourselves so that we can care for others, and so that we can care for babies, their families, their siblings, within the high stressful context that many of us work in. So look after ourselves, and then we can provide the care that is so desperately needed. Thank you.
Thank you so much, Julia. I think all of our speakers today have done a really good job to help explain the challenges, yet also give us some really key tips of how we can incorporate and begin to provide this type of care in our workplace. So thank you so much, Rachel, Dr. Megan, and Professor Julia. We have a decent amount of time. We have about 15 or 20 minutes to open up the time for discussion. So there have been, I think, 3 questions that have come through, and we do have experts on the call and faculty who are here with us today. So please, as I go through the questions, those that feel they can answer, please join in. So the first one is from John, who is from Uganda. He has asked, how do we handle bereavement for the siblings of neonate patients? So yeah, a heavy and complicated topic, but again, if you would like to support John and give some suggestions, that would be perfect. So just welcome those who want to share, they can unmute.
Maybe Joan, do you want to give some thoughts? We haven't heard from Joan Marston yet. It'd be lovely to hear perhaps some thoughts.
Oh, so
Hello,
grateful. Hey, sorry.
I just want to see that I'm visible. Just to say the support of the siblings, and I think Rachel brought this up so well, with the involvement of the siblings from the beginning, and to be able to speak to them in language that is age and understanding appropriate, and to help them to develop memories of their little sibling, and then to recognize that support for them is at the time of the baby's life and death, but that support will be needed for a long time in the future as well. But I think that involvement and the right communication is so important in the beginning. The bereavement, it can be long and complicated. And there's a lot of research showing that bereavement problems can come up many, many years later when someone has lost a very young sibling. So recognition that one has to be on the watch for those kind of things as well.
And I think adding to that, Joan, you mentioned memory, and yeah, making those memories is really important. But also the siblings, the brothers and sisters, they've seen the baby grow in mum's stomach, and then there's no baby. And even quite young children will have some understanding of what's happened, where is the baby. So it's really important that they are involved and that they are supported throughout the process. They were looking forward to a new brother or sister, and now that's not going to happen. Also within refugee settlements or traumatic environments as well, they're building on previous and existing trauma, and so trying to involve them and provide that support is key.
And perhaps also to mention, a child has what we call magical thinking that they might be the cause of the death of their sibling. Maybe they don't want the sibling, they're a little bit jealous of the new one that's coming. And so to recognize that the children may have this magical thinking, believing they're the cause of something, when in fact they are not.
Yeah. And they had an argument with mum, or they cried, and then mum went into hospital and the baby's gone. So it's their fault that the baby's gone. Megan, you were going to talk about, I think in your presentation, sort of memory boxes and making memories.
Yeah, that can be important too. And I just didn't think we had quite enough time. I wanted to leave time for discussion, but I think there's 2 types of memory making that we can do, and this can help the siblings. One type is time, right? Time is such a precious resource for these families because they have so little time with their baby. And so the time they have, having them be together, do some activity, or just make a memory of being together. And the sibling can be part of that, whether it's cuddling or playing or singing, you know, just that short time when they actually make a memory can be important. And then the physical things, like sometimes if the siblings do handprints, like on a paper, which is paint or ink, and then the baby does one as well. And then you have some tangible memory of the time that the two were together, or all the siblings were together. And this can be quite acceptable in a number of cultures. Sometimes taking photographs, you know, that's not always acceptable in different cultures and religions, but seems to be a lot of times handprints are acceptable, or footprints. So those can be very simple things you can do, even if you have very limited supplies. You just need ink and paper, you know, and then the family can have something to bring home, or the sibling can have something and say, I did this with my brother or my sister, my baby sister.
Thanks. And I think one of the things with bereavement care is sometimes we feel as healthcare professionals, we're probably repeating ourselves constantly as we support parents, but I think it's probably even more true with siblings. So just trying to be really patient with the children. If you are the nurse or doctor that's, you know, interacting, and, you know, the sibling is there while you're there, just constantly being reassuring, and probably saying the same thing over and over, even though you felt like you have given them bereavement. I think it's an ongoing. We'll move on to the next question. How do I handle ethical issues surrounding not performing some interventions, such as CPR? We heard a lot in the chat with Rachel, or sorry, the discussion with Rachel and Dr. Megan, that it was quite clear this is not a recommendation. How do we, as healthcare professionals in settings such as this, handle those issues? And I know that we have Dr. Lucy and Junaid on the call. So if you wanted to also bring in some perspective from the field, that would be perfect.
Yes, hello. It's Lucy here.
Welcome. I think you went on mute again, Dr. Lucy. Yeah, now there you go.
Yeah, I guess regarding that question, it is quite difficult, and I think most medical people always want to do everything, and actually it's really important to be able to say this intervention is not going to be in the best interests of the baby, and to be able to say, you know, CPR is not appropriate in this setting. And we had a very low birth weight baby quite recently where we did have that discussion, and we had the same you know, point that we would not resuscitate and perform CPR, because it definitely would not be in the best interest of the baby and indeed the family.
Dr. Romana? Oh, you just got unmuted. Sorry, you were just muted.
Yeah.
Yeah,
Now?
go ahead.
Okay. Very important area. And if, first of all, we need to be comfortable with what we are going to offer for the child and the family. But while we talk to the family, even then we need to be confident and sure of what we are doing. From experience, I feel it really helps to know the evidences. Like you've already mentioned that less than 1 kg weight, if the child is weighing is small for date or weighing so little, then they don't have, the chances are they'll not make it no matter what we do. And then if they have those congenital anomalies, or maybe cerebral palsy, or asphyxia, is if if they have had, that sort of situation at birth, then we know the chances are less that they will make it. And then I go back to the basics of ethics, ethical perspective, to focus on doing the right thing. They don't have autonomy, but the children cannot really share. But we can, talk to their parents if they understand. If they don't understand, then we ourselves, we know that, if we do everything, if the child survives, chances are child will have cerebral palsy or may have other anomalies which will make the child's life very difficult. So we will be prolonging the suffering. Is it really worth it? It's the child who's going to suffer and the parents will suffer all their lives. So these are the choices we can see far ahead, but for family, it's very painful to recognize those issues at that moment. So, maleficence and when we think of not harming and also doing the right thing, the balance and then justice of it all, that how it weighs when we are withdrawing feeding or not offering to feed. And then when we feed, what happens? So it's very important to have all those areas very clear within us when we offer a sort of treatment for the child. So keeping those areas of ethical perspective, the 4 important areas, and the scope of application of those, and knowing the evidence that these are the cases which the chances are that they will not survive, or even if they survive, it'll be painful, they'll be suffering, and the family will be suffering for long term. So, and most of the time in humanitarian settings and in refugee crisis, when the situation is so difficult, we don't even have the resources. So keeping everything in mind, we have to do the best we can. And I think counseling and comforting and spiritual care, and these are the areas we can focus on. So for me, ethical perspective is being very confident with what we know. And also we can talk to our peer group. We can share this with our friends and doctors who have had such experiences. So we are, we have a team that we can go back to and discuss ourselves to be very comfortable and sure. Thank you.
Thanks, Dr. Ramana. I think that was a really well-rounded comment. And I think I love how you ended it, to know that you're not alone, especially as we make ethical decisions with families and also on behalf of patients, that it's really important to know that you're not alone. I'll go to Rachel. There's a few more questions and really interesting questions that have come through. So if we don't have enough time, we will also try and follow up with maybe even a response. We could, I'm sure Megan and I could come up with a document in terms of a response to some of these questions that have come in the chat. So Rachel, if you wanted to respond.
Yeah, just, I mean, mostly what I was going to say have been discussed, but the one thing I would just add in terms of, for me, in terms of ethics of not providing CPR, this issue of not doing harm is probably the most important. So discussing with the team, CPR is a very invasive, one could even say violent form of intervention. It's quite traumatic for everyone involved. And so only doing that if it actually has a chance of benefit. And one thing that we did a lot at Guadalajara, where I worked, was to have the team reflect on what are the numbers of kids that we've actually seen survive to discharge here after receiving CPR. Like in best case scenario, the chances, quite low. And so, when we're talking about a very small baby, having the team think about, in our context, how often does this actually work, was helpful. And then Junaid's question about decision-making with family members, I think is important. So I'd love to leave time for that.
Yeah, there was another interesting one. So hopefully you can stay on for the next 5 to 10 minutes, because I would love to hear people's comments on this one. There's please discuss professional decision making when healthcare workers are junior and can lack experience about how to make a decision as they begin to adopt the palliative care approach. And then does your comfort level begin to change as you get more experience in these situations or not? Does it actually get worse? Kind of like Professor Julia was saying, do we burn out when we have to do things that we are not really equipped or feel equipped to do? I'm going to make a plug for all the work that we do with PalChase and ICPC, and I think being part of a community is a big part of it, but I will open it up to the group because again, we really don't want you to feel alone or isolated in your work. We're really proud of all the things that you do, but please do not feel alone. But if there's anyone else that would like to add their 2 cents, the floor is open. So how do we support people that feel like they lack experience in these really difficult situations?
Erin, maybe if I could say just briefly, I think technology. If I just see how technology is helping us at the present support our colleagues in Ukraine and how appreciative they are of the support they're getting, even though we often feel so helpless and we feel we're doing so little. Just the mere fact that technology is enabling us to keep in regular communication. And I think from our side as well, looking at how do we use technology that they can access. I'm very aware that some of them would have liked to have been on this, but their access to the internet, it's not strong enough, they don't have enough data, and that kind of thing. I think it's a challenge to us to also see how can we provide this kind of webinar in another format that can be more accessible. So I just like to put in a plug for technology and innovation that we need to look at in technology going forward.
Megan, can I suggest something? Some of us can do live streaming of such discussions. I think we will have more audience. And these are important topics that even a non-physician or non-medical person should know. So for awareness, this is how it is. And since we have such excellent faculty, we don't get to meet everyone so often, and it'll be wonderful to spread the word and to create awareness and tag our friends in this area. So live streaming is something that really works, I think, visibility.
Yeah, live streaming might be a good option for some, I think, things. And then also, if we can, we're thinking about how we can offer it asynchronously. So having the PowerPoints be available, and I have taken everyone's email address, so I will share them with you, but that can help our colleagues when they can't join live. It helps them to read the materials. We have a video recording, so if they can access that at some point when they have a bit more internet, you know, if they're able to, and we try and provide everything in a format where you don't have to have a continuous internet connection, where if you just have internet for a few minutes, you can download something. It's not too large of a file, but then you can watch it or read it offline. But definitely the live support does help people. Like I feel like today, you know, knowing that you're not the only one making this decision about 1 kilo babies, you know, you are making a good and ethically acceptable decision that is appropriate care. But you don't know that if you're doing it all by yourself. You feel very alone, and it's better to know that this is the consensus. This is what the experts recommend around the world, you know, in this type of setting.
And I think that links in, Megan, with the question about, I think there was a question anyway about does it get easier as we get more experienced? And I think several people have said it's also about knowing the evidence. So in terms of, for example, this baby under a kilo, we know the evidence, and that's not too hard a decision to make. It's when they're a bit bigger and they're over a kilo, and it's a bit more of a not quite sure. Those decisions can still be challenging to make, and sometimes we get it right, sometimes we get it wrong. So I would say as you get more experienced, you get to know that maybe some of the more clear-cut cases, like they're under a kilo, but you still have those other challenging decisions. But hopefully your experience, we draw on our experience and on our knowledge as we make those decisions. And how do we support, you know, those who are more junior members of staff trying to make decisions? I mean, sadly, that is a reality in many of the situations where we work. We have doctors, nurses who are having to make decisions without having necessarily had that experience. If they've got mobile phone contact, or if they can talk to somebody with more experience, then that is really important, and we would encourage them to do that. And if that's not possible, then to try and debrief with them after the case and try and help them to talk through what decisions they made, what they might do differently next time, and just give them that support and be that listening ear. I don't know if others have thoughts on that one.
I think the session today, a few things have come up, and we are recording it. So we will go back on the chat and just follow up. There's just one more question I want to do. If we can hang on for 3 more minutes, I promise we'll finish. But it's just in regards to the palliative care planning and management. Should we include parents in decision making? And then the question goes on again. Of course, many parents want more advanced care. How do we go about this? And I think these are the kind of skills we want to empower you in. So that's why I'm hoping you can stay on the call for a little bit longer and just see if we can gain some insight from the experts on this call. How do we include parents, and should we, in decision making?
I think we include them by communicating well with them about what's happening with their baby and what, what is the treatment recommendations for the baby. Sometimes there aren't options, right? Like, it's not a menu, it's not a restaurant. You don't just say, here's all the things we could possibly do. Which one do you want us to do? I think the most important thing is for them to profoundly, deeply understand at the level that, a non-healthcare provider can, what's happening with their baby and what are the treatments we recommend. And if there are options, then involving them. But I think sometimes a thing that trips us up or confuses us as healthcare providers is that we think that there are options, but really there's an appropriate direction for care, and that we need to take that. There's not always another way forward. A 1 kilo baby in a Bangladeshi hospital, refugee camp hospital, is probably going to die in any situation, right? Like, if you give intensive care, they will still die. Or you give comfort focused care that doesn't escalate to intensive care, they are going to also die in that situation, right? So then this isn't really a choice, because you shouldn't give care that is going to cause the patient a lot of suffering, like Dr. Romana was saying, without offering them the potential of being well from it, right? You don't want to put a patient through a whole bunch of care that doesn't give you a different outcome. Now, I'm making it a little more black and white than it always is, but I think that sometimes we get a little bit confused about how our options actually should be presented. And the families are depending on us. We're the people who know about the healthcare options. So we have a responsibility to explain the medical piece very well to the family and involve them they understand their own child very well. They know what their family and their whole family's hopes, goals, for the child are. So I tend to approach it in that kind of a way. That's my thought.
I'd agree. It's just like the communication is so key, isn't it? How we communicate, how we provide information, how how we share information. So yes, I believe in involving the parents as much as possible, but it isn't always possible. And if we need to be giving them clear information, so where it is possible to be involved in the decisions, then they have that information from which to make those decisions. But you know, as health professionals, we also have a role in guiding them as well. The number of times I have been asked, well, if it was your baby, what would you do? And whilst that's hard, that it does also give me enable me to guide and to make recommendations. It varies. Joan, do you have thoughts on this?
Yeah, I was just thinking as well, working in different cultures, is that we need to recognize who the decision makers are, because sometimes the decision maker isn't the family in their cultural group. And certainly where I work most of the time, we have large tribal areas. And in those tribal areas, decision making is actually the headman of that particular village. So it's important at the beginning to identify who the decision makers are in that family.
And within a humanitarian setting, those decision makers might not be there. And that also adds complications then as to how decisions are made. And the situation within the baby can change quite rapidly as well. So sometimes you have to make decisions quite quickly. So
And
I think there's no one answer, is there?
No, there isn't. There isn't. I think, again, it goes back to individualized care planning and knowing, recognizing there might be spiritual and religious beliefs that are involved as well.
One thing we could do as healthcare providers is try to open up our creative side of our mind too, and find something in a situation that is very dismal or very unfortunate, and find something the parents can decide about, and really show them that there is something they can decide, and really lift that up. Kind of flipping the narrative of not necessarily doing CPR or something that's super medical, like Dr. Megan was saying. And then we really show what are things that they can do, and then really empower them in that, empower the family.
Yeah, I was thinking that earlier, Erin. I've forgotten, somebody was saying that in a setting we weren't able to do something, and I was thinking we have to try and change that round, and within our context, not looking at what we're not able to do, but what we are able to do, and kind of change that focus.
Just one thought, that every case is different, no matter how similar they look, but every time a family and a child we deal with, it's never the same. Most of the time you're dealing with different dynamics. So we have to really take that in as well. And I'm glad you mentioned culture. It's so important. And culture within a culture, I mean, every family can be different and their dynamics are different.
Well, thank you so much, everyone, for the call. Thank you for staying on a bit longer. A few things have come up that we've taken note of. The desire maybe for some of these sessions to be live streamed, and an option where some of the healthcare workers can easily access maybe experts, so possibly a WhatsApp group. These things we've taken into consideration, we'll talk about, and we'll try to get back to you as soon as possible by email, or by posting on our social media, that sort of thing. So please stay tuned. Dr. Megan, I don't know if you wanted to introduce when the next actual course is coming up, or what the plan is.
Yeah, so we are offering starting in 2 weeks, which is April 22nd. We will be offering the next batch of the Palliative Care in Humanitarian Settings course. The course runs for 11 weeks, and it runs every Friday evening Bangladesh time. So if you are a humanitarian health worker, this course is aimed at you. and it's an overview of palliative care, mainly focused on general palliative care. It's not focused on pediatrics, just so you know, but we will circulate the link for signing up for that course very soon. So you're very much welcome to join. And even if you're not a humanitarian health worker, if you're just interested to know what is the basics of palliative care in humanitarian settings, you'd be very welcome to join the course. If you join, there's no requirement that you stay for every session. You can just receive the materials. If you want to just look them over, you'll get access to videos, PowerPoints, and other materials, as well as the live sessions, 11 sessions with experts in palliative care and humanitarian settings. If you're more of a pediatrics person and you're very interested in like more pediatric palliative care, how do we do pediatric palliative care in settings where humanitarian conflict is going on, or where resources are really limited, like a little bit more like what was today's session, then just stay tuned. We have all your email addresses now, and we know you're very interested. So we will be in touch about our next offerings on just that topic more broadly, because now we are seeing how much interest there is in pediatric palliative care in these settings. So we will be offering something focused on pediatrics as well. We just haven't fully planned it yet.
And that there are also each month ICPCN has webinars on children's palliative care. They're not focused on humanitarian settings though, but look out for information about those as well.
Yeah, thank you, Julia. And we do circulate those usually to all of our group that we have, our listservs. So those are really, really good for all the basic parts of different aspects of pediatric palliative care.
And maybe, Megan, just a plug for the Palchase webinar on the 20th of April.
Yes, definitely. That's a good one too. So in 2 weeks on the 20th, or a week and a half, then there's also that palliative care, looking at a little bit how does palliative care working in Ukraine right now, and how we can support our colleagues in Ukraine and the region. So please, you're most welcome to join, and you'll find that if you follow our Twitter handle, Palchase, or myself or Julia or Joan, it'll be circulated widely through Twitter and email.
And I think that there are a few people from across Africa on here, and I think, Erin, there are plans, aren't there, to do a similar course to this one, but more focused on the African context. So that will be announced soon, I guess.
Yeah, we are really cognizant of the fact that each region kind of has some specialties or specific needs. So through Palchase and the Kenya Hospice Palliative Care Association, we'll be launching a virtual course very similar to the program that Megan is doing in 2 weeks in May. So we will be kind of inundating you with updates. So it's great that you shared your contact information. So if you also, it's also a plug for you to get involved. If you would like to get involved in any of these opportunities, even if you're junior, even if it's the first year you have learned about palliative care, it's okay. We are a very open group, and we're always looking for people that are passionate about learning more and providing really good care to our patients and families. So please don't hesitate to reach out to us. And yes, wherever you are, I guess, good night, good afternoon. I hope you have a great evening, and it's been a really meaningful discussion today. So thanks for all that you do, and we'll talk to you soon. Bye, everyone.
Bye, everyone. Thanks.
Thanks, everyone. Nice to see you. I think we've got all your email addresses taken down, I hope.
Bye-bye.
Julie, are you okay if we share your slides? If you want.
Yeah, I'll send them to you.
I took some screenshots and shared. Is that okay?
Yeah, I think that's okay.
Okay, because I think Bangladeshi positions really needed to. Thanks. Bye-bye.
Today's video and class in our group, okay? Our group.
Bye.
Bye, everyone. Thank you so much, Julia and Joan, for joining.
Thanks for inviting us, and it's been good. Thank you.
Okay, we'll talk soon.
Take care.
Bye.